3 of the 5 medications I am about to describe require no prescription. You can walk into any pharmacy today and buy them off the shelf without speaking to a single healthcare professional. That is exactly what makes them dangerous for anyone over 70. When something is available without a prescription, we stop treating it like a drug. We treat it the way we treat a vitamin or a cup of tea. Harmless. Routine. Something you take every night without a second thought because you have been taking it for years and nothing obviously bad has happened. But here's what your body has not told you. After 70, your kidneys filter drugs from your bloodstream at a fraction of the rate they managed 20 years ago. Your liver metabolizes compounds more slowly. Your brain has become significantly more sensitive to certain chemical classes. A dose that was appropriate for you at 55 can now accumulate to levels that cause falls, memory impairment, and kidney damage in ways that develop so gradually they get attributed to aging rather than to the medication. And here is the part that genuinely concerns me. Your doctor almost certainly knows this in principle. But a standard 15-minute appointment is not designed to systematically review every medication a patient over 70 is taking against age-specific safety criteria. That review requires time, a specific framework, and a physician who has been prompted to conduct it. Today, you are going to learn how to prompt that conversation. Today, I am covering 5 specific medications that illustrate this problem more clearly than any others. All 5 appear on the American Geriatric Society's Beers criteria, the regularly updated, peer-reviewed list of drugs considered potentially inappropriate for older adults. This is not fringe medicine. This is mainstream geriatrics, and it is finally reaching the people who needed it years ago. Stay with me because the 5th medication is the one that shocks people most. It has been prescribed to tens of millions of seniors for years. It is considered so routine that most patients have never been told what it is quietly doing to 2 critical nutrients their brains and nervous systems depend on. I'm Dr. Jake Taylor. Write your country in the comments right now, and if you are new here, subscribe and turn on notifications. I make these videos every week for people over 60 who want evidence-based health information they can actually use. Let me tell you about Margaret. She was 74 and had been taking 2 Benadryl tablets every night for nearly 5 years for sleep. Her doctor had actually suggested it at some point as a gentle, natural-seeming alternative to prescription sleep aids. Over those years, her family had watched something shift, repeated questions in conversation, confusion in places she had always navigated comfortably, words that stopped arriving mid-sentence. Her daughter described it as watching someone slowly step behind frosted glass. A geriatrician reviewed her medication list and flagged the Benadryl immediately. Over the following 7 months, after stopping it under medical guidance, her cognitive test scores stabilized and partially improved. Her daughter told me it felt like getting a piece of her mother back. Not a disease, not inevitable aging, a medication, one that was sold without a prescription for under $10, one that had been recommended to her as safe. Today, I'm going to make sure you never make that mistake unknowingly, and at the end of this video, I am going to tell you exactly what to say to your doctor to review every medication on this list. Here is the one concept that makes everything that follows make complete sense. Think of your body's drug processing system as a network of filters and furnaces. The kidneys are the filters, removing drugs from your bloodstream. The liver is the furnace, breaking those compounds down before the kidneys finish the job. In your 30s and 40s, both systems operate at full capacity. By 70, kidney function has typically declined by 40 to 50% compared to young adulthood. Liver metabolism has slowed proportionally. A drug that cleared your system in 8 hours at 55 may now take 16 or 20 hours to clear at 72. That means the dose you take at 10 p.m. may still be pharmacologically active when you stand up at 3 a.m. for a glass of water. The drug is still in you. You just cannot feel it. That is not aging making you unsteady. That is a drug that has not finished clearing your system, affecting your coordination and reaction time at exactly the moment you are most likely to fall in the dark. Understanding this single mechanism is the key to understanding why every medication on this list is specifically dangerous after 70 in ways it was not at 55. There is a second dimension to this that your physician may not have explained clearly. The blood-brain barrier, the protective layer that controls what substances from your bloodstream can reach your brain, also becomes more permeable with age. This means that psychoactive drugs, medications that affect brain chemistry, now reach the brain more easily and in higher effective concentrations than they did when you were younger, even at the same dose. Combine slower clearance with greater brain permeability, and you have a situation where a standard dose of a sedating or brain-affecting medication delivers a significantly larger pharmacological effect to a 72-year-old than it does to a 45-year-old. This is not a rare individual sensitivity, it is predictable physiology, and it explains why the same sleeping pill that worked smoothly for you at 58 may now be doing something quite different to your brain and your balance at 74. Now, the first medication, benzodiazepines. You probably recognize the brand names more than the drug class: Xanax, Valium, Ativan, Klonopin, prescribed primarily for anxiety and insomnia, and genuinely effective at both in the short term. That effectiveness is part of why they are so widely used. It is also part of why they are so consistently dangerous for older adults. After 70, the brain's sensitivity to benzodiazepines changes significantly. Because the liver processes these drugs more slowly, they accumulate. Multiple systematic reviews confirm that benzodiazepine use is associated with a substantially increased risk of injurious falls in older adults, falls serious enough to require hospitalization. Falls are the leading cause of fatal injury in adults over 65 in the United States. We are not talking about a minor side effect. We are talking about the mechanism that ends independence for more older adults than almost any disease. Beyond the fall risk, benzodiazepines consistently impair memory, attention, and processing speed in older adults, even in people who feel they have fully adapted to the medication and no longer notice any effect. The adaptation is the problem. The drug is still working on your brain. You have simply stopped noticing it doing so. The American Geriatric Society explicitly lists the entire benzodiazepine class on the Beers criteria as drugs to avoid in older people. Let me tell you about Dorothy. She was 72 and had been on Ativan for anxiety since her husband's illness 5 years earlier. She was careful with it, taking the lowest prescribed dose. She had fallen twice in 18 months, both times at night getting up for the bathroom, both times attributed by her physician to general unsteadiness. When a geriatric specialist reviewed her medications, the pattern became immediately clear. The Ativan she took at bedtime was still circulating in her system at its peak sedating effect between 2 and 4 a.m., exactly when she was getting up in the dark. She was not unsteady, she was medicated. Her previous physician had never connected the falls to the benzodiazepine because they occurred hours after she took it, and she described herself as feeling fine. After a supervised 8-week taper, she did not fall once in the following year. She told me, "I thought I was just getting old and wobbly. I did not know I was drugged every time I got up at night." If you are currently prescribed Xanax, Ativan, or Valium, do not stop it suddenly. Abrupt discontinuation of benzodiazepines can cause serious withdrawal, including seizures. This is a conversation for a supervised gradual taper with your physician. I will tell you exactly what to bring to that appointment in a few minutes. The second medication genuinely surprises people because it costs $6 at any drugstore. Diphenhydramine. Sold as Benadryl for allergies and as the active sleep ingredient in Zizquil, Unisom, and Tylenol PM. Millions of older adults take this every single night, confident that if it is available without a prescription, it must be safe for them. It is not safe for them, not after 70, not taken nightly for months or years. Diphenhydramine is one of the most potent anticholinergic compounds available over the counter. Anticholinergic means it blocks acetylcholine, the primary neurotransmitter your brain uses for memory formation and retrieval. A landmark prospective cohort study published in JAMA Internal Medicine in 2015 followed 3,434 adults aged 65 and older for over 7 years. Researchers found a clear dose-response relationship between cumulative anticholinergic drug use and dementia risk. Those in the highest use category had a 54% increased risk of developing dementia compared to non-users. The most common anticholinergic drugs in that study were first-generation antihistamines, exactly like diphenhydramine. A 2019 study examining nearly 60,000 dementia patients corroborated those findings. This is not a theoretical concern. This is a documented, dose-dependent relationship between a drug sold in every pharmacy without a prescription and the condition that most older adults fear more than any other. The practical action here: check every sleep and allergy product in your medicine cabinet tonight for the word diphenhydramine. If it is there, it is an anticholinergic. Bring it to your next appointment and ask about alternatives that do not carry this risk now. The third medication is one that tens of millions of seniors reach for the moment their back or knees flare, and the kidney damage it causes accumulates silently without a single symptom until the damage is already advanced. Ibuprofen and naproxen, sold as Advil, Motrin, and Aleve. For occasional use in younger adults, the risk is manageable. For regular use after 70, the picture changes entirely. Your kidneys are responsible for filtering these drugs from your bloodstream. With kidney function already reduced by 40 to 50%, ibuprofen circulates longer, reaches higher concentrations, and progressively damages the very tissue responsible for clearing it. The 2023 update to the Beers criteria specifically reinforced the need for caution with NSAIDs in older adults, given how frequently this class causes acute kidney injury in people who believe they are taking something harmless. The gastrointestinal risk compounds the problem. The stomach lining becomes more fragile with age, and NSAIDs directly impair the protective barrier that lines it. According to the NIH, older adults who use NSAIDs regularly are 3 to 5 times more likely to develop a serious gastrointestinal bleed than younger users. Those bleeds are significantly more dangerous in someone over 70 with less physiological reserve. For anyone managing high blood pressure, there is a third problem. NSAIDs raise blood pressure and increase fluid retention, directly increasing heart failure risk. Are you currently taking ibuprofen or naproxen regularly for pain? Type yes in the comments right now, because I am going to tell you what the evidence actually supports for senior joint pain without any of these risks, and it works better than most people expect. William was 71 and had been taking ibuprofen twice daily for knee pain for 3 years. His physician had checked his kidneys at his annual physical and described them as fine. What had not been done was a comparison to his kidney function 3 years earlier when the ibuprofen started. When that comparison was made, his kidney filtration rate had declined by 22% over the 3 years of regular NSAID use. No single measurement had triggered alarm. The trend only became visible when someone looked at the trajectory. His cardiologist subsequently noted that his blood pressure, previously well controlled on medication, had required 2 dose increases during the same 3-year period. No one had connected the blood pressure changes to the ibuprofen either. When the ibuprofen was replaced with a structured acetaminophen protocol and targeted physical therapy, his blood pressure stabilized within 4 months without further medication adjustment. He said, 3 years of damage from something I was buying at the supermarket. Nobody told me to watch for this. Before I continue to the 4th medication, I want to stop for a moment. If this video is connecting information that nobody has put together clearly for you before, subscribe right now. We publish every week. If you want to make sure you see next week's video, subscribe takes 3 seconds. And stay with me, because the 5th medication is the one that surprises people most. The 4th medication is prescribed to roughly 10 million Americans annually for sleep. Zolpidem, sold as Ambien. The FDA issued a specific safety communication about this drug in older adults, noting that elderly patients can have far higher blood concentrations of Zolpidem the morning after taking it compared to younger users taking the identical dose. This means they are still pharmacologically sedated when they wake up. They do not feel drugged, they feel like themselves, but their coordination and reaction time are compromised without their awareness. Research consistently finds that zolpidem use is associated with nearly twice the risk of hip fracture in older adults. Hip fractures in adults over 70 carry a 1-year mortality rate of 20 to 30%. That means up to 3 in 10 seniors who break a hip may not survive the following year, often due to complications including blood clots and pneumonia during recovery. A sleep medication, causing falls, causing fractures, causing deaths, in people who felt they were simply managing their insomnia. There is an additional problem that drives dependency. Zolpidem suppresses the deep restorative stages of sleep while increasing lighter sleep stages. So you fall asleep faster but wake up less restored, which drives continued use. Higher doses. Dependency. The drug solves the symptom of sleep onset while worsening the quality of the sleep itself. Let me tell you about Harold. He was 78 and had been on Ambien for 6 years. He had taken one fall 18 months into his use that his physician had attributed to an unsteady moment rather than the medication. He had not connected them. When a geriatric review flagged the zolpidem, he was tapered off over 8 weeks with his doctor's supervision and referred to cognitive behavioral therapy for insomnia. At 3 months off the medication, his sleep was measurably better than it had been in years by his own assessment. His daughter said he moved differently, more secure, more present. He said, "I thought the drug was helping me sleep. I did not know it was the reason I never felt rested." Now, the 5th medication, the one that surprises people more than anything else on this list because it is considered so standard, so routine, so widely prescribed that most patients have never been asked to question it. Proton pump inhibitors, omeprazole, Prilosec, Nexium, Prevacid, among the most widely prescribed drugs in the world. For short-term use of 4 to 8 weeks, they are appropriate and effective for acid reflux and stomach ulcers. The problem is that most older adults are not taking them for 8 weeks. They have been on them for years, sometimes decades, without reassessment. Long-term PPI use quietly depletes 2 nutrients that the aging body depends on critically. First, vitamin B12. Your stomach acid is essential for extracting B12 from food. Suppress that acid for years, and B12 absorption drops sharply. Research published in JAMA found that long-term PPI use was associated with a 65% higher risk of B12 deficiency. In older adults, severe B12 deficiency causes peripheral neuropathy, the tingling and numbness in hands and feet that millions of seniors experience and attribute to aging, and cognitive decline that closely resembles early dementia. Second, magnesium. The FDA issued a specific safety communication warning about dangerously low magnesium in long-term PPI users. Low magnesium affects heart rhythm and nerve signaling in ways that compound cardiac and neurological risks in older adults who are already managing both. There is a third consequence that is less discussed but clinically significant. Long-term suppression of stomach acid alters the gut microbiome. Stomach acid is one of the primary defenses against pathogenic bacteria entering the digestive system. When that defense is chronically suppressed, the composition of the gut bacterial population shifts in ways that increase susceptibility to certain infections, including Clostridioides difficile, a serious intestinal infection that is disproportionately severe in older adults. This is an additional risk that most patients on long-term PPIs have never been informed about. Robert was 76. He had been on omeprazole for 9 years, originally prescribed for an ulcer that had resolved long before anyone thought to reassess the prescription. He had been living with severe foot numbness and what his family described as a fog he could not shake. His B12 came back critically low. His physician tapered him off the PPI over 8 weeks, started aggressive B12 replacement, and shifted his reflux management to dietary changes and a safer approach. 4 months later, the neurological symptoms were clearly and measurably improving. 9 years. A prescription, no longer clinically indicated, caught with one thorough medication review. Here is exactly what to do after watching this video. Write down every medication you take. Prescription and over-the-counter. Yes, include the Benadryl, the Advil, the omeprazole. Over-the-counter does not mean safe after 70. Bring that list to your doctor and ask specifically for a geriatric medication review, requesting evaluation against the American Geriatric Society Beers criteria. Those exact words will be immediately recognized by any physician who follows current geriatric guidelines. For pain, ask your doctor about acetaminophen as a first-line alternative. It is significantly safer for kidneys and the GI tract in seniors at the correct dose, no more than 3,000 milligrams total per day for adults over 65. For sleep, ask for a referral to cognitive behavioral therapy for insomnia, known as CBTI. Studies consistently show it outperforms every sleep medication for long-term outcomes. No drug interactions, no dependency, no morning impairment. It addresses the cause of insomnia rather than masking it. If you have been on a PPI for more than 6 months, ask your doctor whether you still need it and whether your B12 level has been checked recently. This is a single question that could prevent years of unnecessary neurological decline. A critical note before we close: do not stop any prescription medication without speaking to your doctor first. Benzodiazepine withdrawal without medical supervision can cause seizures. For anyone managing heart disease, kidney disease, or multiple prescriptions, medication changes require careful, coordinated medical oversight. These 5 medications are not automatically dangerous for every person in every situation. But in adults over 70, used long-term without reassessment, the research is clear and consistent. Your body has changed since you first started taking some of these drugs. Your medication list may not have kept pace. That is not a failure on anyone's part. It is a gap that a single informed conversation with your physician can close. Let me give you the exact language for that conversation, because arriving with the right words makes the appointment significantly more productive. Say this: I would like to request a geriatric medication review today with evaluation against the American Geriatric Society Beers criteria. Those words will be immediately recognized by any physician following current geriatric guidelines. Bring your complete medication list, prescription, and over-the-counter with the dates you started each one. Ask specifically, is this medication still the most appropriate option for me at my current age and kidney function level? And for each prescription that has been in place for more than 2 years without reassessment, ask, what was the original indication for this? And does that indication still apply? That conversation could take 15 minutes. The consequences of not having it can take years to appear and much longer to reverse. The timeline of what to expect when medications are appropriately adjusted. Within the first 2 to 4 weeks of stopping an anticholinergic sleep aid under medical supervision, most people notice that their thinking is clearer in the morning and that words and names are more accessible. Within 1 to 3 months of benzodiazepine tapering, coordination improves and fall risk decreases measurably. Within 3 to 6 months of stopping unnecessary PPI use with B12 replacement, peripheral neuropathy symptoms often begin to improve in people whose deficiency was the cause. Within 4 to 6 months of replacing NSAIDs with appropriate alternatives, blood pressure control typically improves in people where NSAID use had been silently contributing to elevation. None of these timelines are guaranteed. Every person's situation is different and requires individual medical assessment. But the direction of the evidence is consistent across thousands of studies and millions of patients. You have managed your health carefully for decades. You take your medications as prescribed. You show up for your appointments. You have done everything you were told to do. What you may not have been told is that the medications themselves need to be reassessed as your body changes. That is not a criticism of your physicians. Most of them are managing high volumes of patients with limited appointment time. A systematic medication review for every patient over 70 is recommended in geriatric guidelines, but is not consistently implemented in standard primary care. You are now the person in the room who knows to ask for it. Tell me in the comments, how many medications are you currently taking, prescription and over-the-counter combined? And have you ever had a full geriatric medication review where someone specifically evaluated your list against age-appropriate safety guidelines? I read every comment, and your answers help me understand what this community needs most. If this video gave you something you needed, share it right now with someone over 70 who takes a sleep aid or a daily pain medication without questioning whether it is still appropriate for their body at their current age. Someone who has had a fall in the last year and never connected it to their medications. Someone whose family has noticed changes in their memory or their sharpness and attributed it to aging. That conversation could genuinely protect their independence. I'm Dr. Jake Taylor. Subscribe if you have not already. Take care of yourself, and I will see you in the next video.